Well, we are so happy to welcome everybody straight out of Africa. Drum roll, please. Dr. Amy Sims Sunyahumbe. I've practiced this so much. Sunyahumbe.
Yeah.
Is that right?
Yeah.
All righty. And this is all about Dr. Amy. She went to University of Maryland Medical School after graduating in biology in Brown University, where she was captain of varsity hockey team. Yay! You never have enough physical activity. She did her training in pediatric. Well, she got her master's in public health after she got her MD degree, and then she did training pediatrics training, and then a fellowship, which is specialized 2 years of additional training at Children's National Medical Center in DC, which is pretty prestigious. And in fact, actually, I was talking to, and I don't think this would betray any confidences, but Dr. Heilman's first child, he lived up in that area and was born with a severe heart defect. And they rushed him within hours to this hospital. Now the kid's 19 and 6'7", but it's because of this place that his son lived. And then she got a Fogarty Fellowship in Global Clinical Research. I didn't know what that was. So a Fogarty Fellowship is a collaboration between Fogarty Clinical International Group and the Fulbright people to foster clinical research and bring health resources to lower resourced countries. And this is a very prestigious award. She was also one of the inaugural group of doctors who was sent to Africa under the Baylor AIDS Initiative program and helped in research and care for the pediatric patients there with AIDS. She's clinically doing clinical research, and believe me, if you want the state-of-the-art medicine, you gotta be going to people who are doing research because they're on the cutting edge. Because until we have the cure, you gotta be looking for that cure to make it better. She also directs the cardiology clinic in Lilongwe in Malawi, and she's married, has a high-tech husband, and she has 2 twin boys. So Dr. Amy is going to, and that's Sunyahumbe, and she is going to introduce 2 of her colleagues that are here.
Thanks so much. First of all, thank you so much for that really kind, really accurate introduction. Thanks, Diana. Thanks so much, Frankie. So before I get started, just wanted to introduce my my global health colleagues sitting near Meg over there. There's Teresa and Taylor Napier Earl, and then there's Carlton sitting next to Karen there, who's an intern in global health, and they're part of what all makes this happen. So welcome to Eagles Trace. So again, Frankie, thank you so much for that kind introduction, and thank you so much for setting this up. This has been really a wonderful experience thus far. And let's get started. And then I also wanted to thank my parents, Lori and Hank Sims. Thank you for this opportunity. here and welcoming me here, and of course, as usual, all of the goodies. And in addition to the cookies and the goodies over there, there is a raffle for some bowls that are from authentic Malawi bowls. So hopefully you got your raffle ticket. Thank you so much. And then there's the Global Health Annual Report. If you're interested, take one. If you're not interested, don't take one, because I think we have about 30. You could share with your neighbor. And then a couple other things that describe what we do. So again, thank you so much. Wow, this is really a full house. This is great. And so before I start, this is just going to be a little bit of a talk about who I am and what I do. So I'm a pediatric cardiologist, so that means that I'm a physician and I take care of children with heart problems. And so you'll hear me talk about congenital heart disease, and that means that, just like Frankie described, that means that there's a child born with a heart problem. And that happens in about 1 in 100 live births, and that is here in Houston or in Malawi, Africa, where I work. And then I also take care of children with acquired heart problems, and so those are children that are born with normal hearts, but then for some reason, and I'll talk a little bit about this, they develop heart problems. And what I do is I spend most of my time in Malawi, Africa. So I live there for about 9 months out of the year, and then I am here for about 3 months out of the year, and very happy to spend lots of time with my parents here when I'm in town. And so I had to show this slide because my children are currently in Malawi, and they were very excited that I was, and very jealous that I was spending time with Grammy and Grandpa in their favorite trick-or-treating spot. So thank you for all who have indulged us in trick-or-treating. Oh, I am the Incredible Hulk. That is not the projector. Thanks, Mom. So I also wanted to start off with showing my actual family and my work family in Malawi. So on the left is my husband Doug and my twins Luke and Nathan, and myself. And then on the right are 3 of our core Malawian team members. So on the left is Treasure, and he's a clinical officer, which is about the equivalent of like a physician assistant here in the US. And then there's me, and then there's Abisai, who is a clerk that I've worked with that's really helped me translate and done various things since I first started working in Malawi in 2006. So I've known her for a long time. And then all the way to the right is Tayamika, who's a cardiology research nurse that I work with that really helps hold everything together. So I wanted to show on the left here, this is our Baylor, Texas Children's Hospital Center of Excellence in Lilongwe, Malawi, where I work. And so this is really the center of where everything happens. So this is where my office is. This started out as really a primarily clinic for HIV positive children. And so this is where I work. I actually helped to open this clinic in 2006. And it was designed to take care of children with HIV. And since over the past almost 20 years, we've really expanded. And so now the Baylor Texas Children's Program in Malawi, besides supporting pediatric cardiology, myself, we support pediatric surgery, OB-GYN, hematology, oncology, and other general service lines, emergency room also. And then on the right, this little red sliver, so sorry my pointer's not huge, this little red sliver is Malawi. So it's a small country in Southeast Africa, where I call home. It's a beautiful country. You are all welcome to come visit me. And it's affectionately referred to as the warm heart of Africa, because the people are just, in general, very nice and very welcoming, much as I've experienced here at Eagles Trace, actually. And then here's a little close-up of Malawi, and you can see almost all of the east coast of Malawi is a beautiful lake called Lake Malawi. And Lilongwe is where I'm based, and this is in the central region of the country. And then you might hear me refer to my colleague. I'm one of 2 pediatric cardiologists in this country of 21 million people. And my colleague who I helped to train is based in Blantyre, which is in the southern region of the country. And sorry, I should have said in the beginning, please, I hope this is a little bit informal, please feel free to ask questions along the way if you'd like, and we'll have plenty of time for questions at the end also. So I consider Malawi a high resource setting when you look at the warmth of the people, the beautiful lake, and the landscapes. But it is a low healthcare and low resource setting because it's unfortunately a very poor country. So it's about 22 million people, and over 70% of the population live on less than $2 a day. It's the 4th poorest country in the world and has a very high infant mortality and under 5 mortality rate.
What are the comparable numbers in the US, Dr. Amy?
Oh, that's a good question. Do you want to ask your chatty?
Yeah.
Maybe at the end, I know.
We'll get it.
Yeah.
Okay.
That is a good question, and I don't know off the top of my head. But we have much lower infant mortality and under 5 mortality rates. And so in this country of 22 million people, we have 2 pediatric cardiologists. Actually, right now we have 1 because I'm in Houston. And there's a large burden of pediatric cardiac disease. And so in addition to the children that are born with heart problems, we have the additional burden of children that acquire heart problems. And unfortunately, we have pretty limited access to pediatric cardiac surgery in Malawi. There's just one surgery that is performed there, and the rest of them, if we're able to, we send them abroad for surgery. And so this is just actually these are kind of old pictures, but pictures of the public hospital, Kamuzu Hospital, where I work. And so this, up here, this is our previous pediatric cardiology clinic. So as you can see, we're really busy, lots of people. This was actually in what they call the library. So we, any of you who've done ultrasounds or echoes know that we kind of try to keep it pretty dark, as you know, Stuart, to try to see the pictures. So which isn't always easy in Malawi. So we try to cover the curtains, and then we actually put the child on there was like a little desk there, and then we would do the ultrasound. So you'll hear me talk a lot about ultrasound and echo, and that's really our mainstay for diagnosing pediatric cardiac disease, is using these ultrasounds in order to look at the hearts of these children. And this is the public hospital ward, and it's not uncommon in the ward for it to be very busy enough to have 3 children per bed. And that's kind of the norm. And unfortunately, there's not a lot of nurses, and so children are actually required to have, and actually even if an adult's admitted to the hospital, to have a guardian there with them to help take care of them and do a lot of the duties that here we would expect nurses to do. So this is I like this picture because I look young because I am young in this picture. Because this was taken a very long time ago, and it's just to kind of to prompt me to tell a little bit about my history with Malawi, which Frankie did a really nice introduction again. So I first moved to Malawi in 2006. Before I trained in cardiology, and I was a general pediatrician tasked to take care of children with HIV. And we helped to open that clinic and saw lots of children with HIV. I then moved back to the US and I did my fellowship. I did more training in to be trained as a pediatric cardiologist. Then moved back to Malawi for the Fogarty Fellowship, which you nicely explained. And then in 2013, I was able to get my position with Texas Children's and Baylor College of Medicine. And so very happy to have this combination. So again, I spend 9 months in Malawi and 3 months here. And when I'm here, I do clinical service at the main hospital and also do clinics around the Houston area. And this is just a picture to show that I use my echo in various places in Malawi. This is actually a school, as you can see with the chalkboard there. Yeah, and a child that we kind of put on 2 desks, and I'm able to do my ultrasound there. And that's, you know, in contrast to Texas Children's Hospital, where I also work, where I did my clinic this morning, which is the #1 in the nation for cardiology and heart surgery in children. And so just to compare, in Malawi, I'm one of 2 pediatric cardiologists in the country of 21 million people. At Texas Children's, I'm one of more than 70 cardiologists just at Texas Children's. So quite different. And it's really nice for me to be able to spend time in both environments. And so this is a pie chart that a trainee of mine did, and this shows our patient population in Malawi, so in Africa that we see. And so this is here, we have just about half congenital heart disease and about half acquired heart disease. And so I'm gonna, again, congenital is children that are born with heart problems, acquired is children that acquire them. And this is really different than the makeup of children that we see here in Houston, in which it's mainly children that are born with heart problems. And I'm going to talk just a couple slides about rheumatic heart disease, because rheumatic heart disease is really the focus of my research, and it's a subject that I'm really passionate about. So some of you may have even known people that have had rheumatic heart disease or acute rheumatic fever. But oftentimes people, when I talk to medical students now, they haven't known it in the US, because it used to be a disease that was pretty common in the US, and now it's actually very uncommon in the US, but common where I work in Africa. So rheumatic heart disease starts with a strep infection. And so the strep infection can be from a strep throat infection or can be from a strep skin infection. And if not appropriately treated, then a child can develop acute rheumatic fever. And acute rheumatic fever is a reaction to the strep bacteria. And it's an autoimmune reaction. And then from there, through multiple cycles, there can be heart damage. So the heart valves that open and close in the heart can become very scarred and damaged. And so this turns a healthy young child into a 13, 14, 15-year-old with heart failure, unfortunately. And it's preventable with penicillin, and so that's something that I'm really passionate about and really trying to work towards, is being able to get people treated early so we don't have these a very severe disease. So some people now think that rheumatic heart disease is rare, but it's not. It affects over 55 million people. And it has recently overtaken HIV. So HIV, where my big, beautiful clinic in Lilongwe was built for, affects about 40 million people worldwide. So rheumatic heart disease affects more people than HIV. And this is a map which shows where we now see rheumatic heart disease. And so, so the little Malawi that I previously showed you, I see my pointer here, is right here. So right in this red hot zone of rheumatic heart disease. There's also a kind of scattering in some indigenous populations in New Zealand and Australia also. So I wanted to show this picture because this is a patient of mine who is a 13-year-old with rheumatic heart disease, whose heart disease is so severe that he needed his mom to carry him across the hallway, just from his hospital bed to my clinic across the hall. And in Malawi, a 13-year-old is really expected to start contributing to the family. Going to school, and then also, maybe having some odd jobs, doing some things to help with the household. And so they're not expected to be this huge burden that this child is, that he can't even walk across the hallway. And so it is a big problem for the entire family when one person is affected by rheumatic heart disease. But it doesn't have to be that way. So this is a picture, an example of someone who had rheumatic heart disease, but it was caught early, and they were put on medication, and they were able to go back to school. So this is really the goal, is to prevent rheumatic heart disease, catch it early, so that we don't have that really horrible sequelae. But unfortunately, the previous slide, that's how my patients present. Unfortunately, they often present in very, very late stages. So this is Joseph, and he really wanted for me to show his picture today, both him and his mom. So Joseph had congenital heart disease. So the name of his heart problem was tetralogy of Fallot, which we see in Malawi and we see here in Houston, and we see everywhere. And generally here, it's operated on and fixed when babies are less than 6 months old. Joseph struggled and was in and out of the hospital for the first 2 or 3 years of his life. I mean, it's amazing that he really made it that far. And again, yes, it was very hard for him, but also for his family. So in Malawi, one of the biggest expenses families have is transportation to and from healthcare appointments and hospitals, and so his family was really struggling to take care of him. But then we were able to send him to India, and he had his heart repaired. And now I only get to see him once a year when he comes for his checkups, and he's in school and he's doing really well. So this is also one of the goals. So what does pediatric cardiology look like in Malawi? So I talked a bit about the clinical care that we do. So I help to lead a pediatric cardiology clinic where we take care of children with heart problems. I also help to lead inpatient consults. So when children are admitted to the hospital and they need echocardiograms or they need opinions on cardiac problems, and I help that team. We're really excited, and I'm going to show a picture later, of our Malawi residency program that's supported by, in part by Baylor Texas Children's philanthropy, and that we're really excited about because that's training really the next generation of Malawian pediatricians. I spend a lot of my time on capacity building and mentorship. As I've said probably a few times now, 2 pediatric cardiologists for 21 million people is not enough. So I will train anybody that's interested in holding an echo probe to diagnose heart problems, and I do, and I think we're really starting to make a difference. So here in the U.S., I think people say doctors are supposed to do certain things, and medical assistants are supposed to do certain things, but there we just don't have the doctors to do everything. So we train a lot of people that traditionally wouldn't be trained to make these diagnoses there. We also support other service lines. So like I talked about before, we have an HIV service there, we have surgical service there, we have pediatric oncology, which we support there. We have an ACGME approved fellowship, so we help to send fellows that we train here at Texas Children's to Malawi to also learn there. And then we have been fortunate to be supported by some research grants in the past, and we hope those will continue. But unfortunately, we're not super optimistic about that. Yeah, so this is just some of the capacity building that we've been doing. So on the left is Wilson, who's a radiographer or a radiology tech. Who, I think here would be, doing ultrasounds and then sending them to Stuart to be read. But in Malawi, he's expected to do the ultrasound, to read the ultrasound, to put the report down, and so it's a lot to expect, but people really are rising to the occasion. And then on the right is Treasure, who's the clinical officer who I mentioned in the beginning. I've also trained him to do echocardiography, and he co-leads the clinic and the service with me there, and he's doing a great job. And so this is again our map of Malawi and our beautiful lake. And this is our team that we've started doing outreach, and so this map, you probably can't see it very well, but this is divided into the different districts of Malawi, and so what we want to do is go to each district and train people to do what we do, and the goal of this is to have children caught earlier, so they present like the second girl that goes to school, and not the first child that's already very sick by the time they come to see us. And so we've started doing some in-person training along with some remote training, which we're really happy about. And for some reason, when we did this training, they gave me that broom as a gift. Maybe they knew I was a little messy. And then these are just some pictures of just some of the trainings that we've been doing. I'm especially proud of this one. I think my parents who are educators will understand this. This is Treasure, who I trained, who now leads these trainings himself. So I'm kind of like the grandparent trainer, which I enjoy. And these are 5 of our pediatric registrars, or we call them registrars in Malawi. They're residents here, so they're doctors and they're training to be pediatricians with support from Baylor and Texas Children's. And we're fortunate that cardiology is now able to be a core rotation for them, and then I'm able to be integral in their education, which I really, really enjoy. And when they talk to me, at least 3 or 4 of them say they want to be cardiologists. So we'll see. And then this is Norbert, who I think really will be a pediatric cardiologist. I spent a lot of time training him in echocardiography, and he's really wonderful, and I think will make a great pediatric cardiologist in a few years. So we have lots of future directions if we're, which we're really hoping to expand. So we're hoping to expand our clinics, really expand our mentorship throughout the country, improve access to cardiac surgery so that we can help more children like Joseph get cardiac surgery and get well. And we'll continue to support and expand training opportunities from both our American trainees going there and then also helping to support our Malawian trainees. So thank you very much. This is Zikomo, which is thank you in Chichewa, which is the official language of Malawi. And thank you very much for your attention, and I'm happy to answer any questions.
So what motivated you to go to Malawi?
So really good question. So I first went to Malawi in 2006 before I trained in cardiology. And I had applied to the Baylor Pediatric AIDS Corps program. It was the first year it was out. They actually sent 50 doctors that year, and I was really excited about it. I had already gotten into my pediatric cardiology fellowship, so I knew I would be coming back at that point. I thought it was going to be a year. And so when I applied, they originally said, sorry, since you're only available for a year, we don't want to offer you the job. So they didn't offer me the job. And then they called, I got a call like 2 weeks before, right, Dad? Like it was like 2 weeks before I was expected to go, and they said, we have a new donor, we have a spot for you. And so let me just back up a second. So Baylor Global Health had I think 5 countries in Africa where they support. And so when they called back, they said we have a spot for you, and the spot is in either Malawi or Botswana, and you choose. And so my choices were Malawi or Botswana, and they described Botswana as Africa Light. Like pretty developed with shopping malls and traffic lights and that sort of thing, and Malawi as a very poor country in need of a lot of help, and so that's how I chose Malawi initially back in 2006, and then I ended up extending my stay, so I lived there 2006 to 2008 as a pediatrician, and then just felt a connection there, and so then throughout my career really made it a goal to go back there.
Okay.
Yes.
Yeah, I take it from what you said, that rheumatic fever is the primary cause of acquired heart disease. Are there other things that cause that? And are there other ways of addressing it? You mentioned bacteria. Can you stop it even before it becomes a problem? And how common is rheumatic fever or other causes?
And repeat the question, Dr. Amy, repeat the question.
Oh, okay.
Or summarize.
There's 2 questions. So the first one was other causes of acquired heart problems besides rheumatic heart disease.
Right.
And so I'll answer that. I'll answer that one first. Yes, there are other causes. The other big acquired heart problem that we see is cardiomyopathy. And cardiomyopathy means that the heart just isn't squeezing very well. And we see this in children in Malawi more than we see it in children here. And unfortunately in Malawi, we don't have all the testing to find out what's causing it. But in general, cardiomyopathy can be caused by various bacteria, viruses. It can be caused, idiopathic, which means we don't know. It can be nutritional. So very different causes of that. And then your next question
You
was.
mentioned bacteria a couple times
Yeah.
now. So is it water issues? Where's
Yeah, so rheumatic disease comes from strep bacteria, and the strep is not so much in water, but it's more associated with overcrowding and poor sanitation, and so and in fact when it was prevalent here in the U.S., so it basically penicillin prevents acute rheumatic fever. But we saw the curve of the acute rheumatic fever go down really before the advent of penicillin in the US, really with the increased sanitation projects throughout the US. So in the US, it was a combination of increased hygiene and antibiotics. So penicillin prevents acute rheumatic fever. So the mainstay of treatment for children that have acute rheumatic fever to prevent them from having serious heart problems is benzathine penicillin, which is an injection that they get every 28 days that basically keeps the penicillin in their system and helps to prevent further strep infections. But that's one of the problems. We're not catching it early enough, so that really makes a difference, unfortunately. Yeah. So good questions, and we knew all the answers to those. I think we got everything solved. Yeah.
So I say you have that nice equipment. I stood up a molecular biology lab in Tanzania from scratch. And my biggest problem was I could get nothing repaired.
Yeah.
How have you addressed that, or have you been able to address that?
Yeah, so that is an excellent question. So this, so you've seen, so this we affectionately call Philip. It's a Philips echo machine that you're right is an expensive piece of equipment that we were able to obtain through our research grant in 2011. So this is way past its the time that this echo machine should be, resting in the Eagle's trace of echo machines. So I mean, one of the things is that we're just very fortunate that it's still going. I've learned, I'm not generally a very handy person, but I've learned a lot about repairing the machine. And in talking to people and looking up things on YouTube. We've replaced a lot of parts as we go, which are, it's easier to replace a probe than the whole machine. The thing that we plug it into has burned out a couple times, so we've been able to replace that with some donations that we've gotten. And we've also, and people make fun of me that I'm very notorious about who uses it, where it gets put back, like how it's taken care of, how it's cleaned, so it doesn't break, because we really rely on it so much, and it's unfortunately I think it's not going to last too long. Go ahead.
Well, the problem is, we have it here with our automobiles. You used to be able to open the hood, get under the hood and fix it.
Uh-huh.
And And as you get newer equipment, it gets so much more complicated
Yeah.
that you outstrip your ability to keep it going in some of these
Yeah,
places.
yeah, yeah, exactly. And this this machine that we use at the Central Hospital is a pretty complicated machine. We have for when we train people in the I don't know if you can see in this picture, but when we do our outreach and we train people in the district hospitals, we use handheld echo machines, which are smaller, portable, more portable, cheaper. They don't have all the bells and whistles that Philip has, but they don't need them. So so you know, using kind of less expensive technology in other places is another thing that we're trying to do. Question. Oh, yes.
Is India the closest place you can go to have this kind of surgery?
That's another really good question. So when I started working in Malawi, we would send children to South Africa because South Africa also has a very good surgical program with really good outcomes and has nice pediatric cardiac surgeons there. So there's a lot of things that kind of went into play. One was politics, which I don't completely understand. The second was that South Africa has a really long waiting list for its own patients, and so it was difficult for them to handle the increased burden of Malawians coming in. And then the Indian hospitals are just cheaper. So the Malawi government has a package with this Indian hospital, and they're able to do most pediatric cardiac surgeries for $7,000, which is
Wow.
I mean, I think you guys know about medical bills. Like this is I mean it's really kind of like an unbeatable price, and they do a good job. So it's that's kind of how we ended in India. But there also are some organizations that sponsor children to come here. So we have had some children come to Houston. We've had some other children go to the Netherlands, to the UK, to Italy, went to Korea. So they've kind of gone all over the place. But when the government does pay for it, it's usually India.
What city?
Yeah.
Is it Mumbai or Delhi?
It is. Frankie, you're really stumping me today.
That's okay. Don't worry.
It's not Mumbai or Delhi. It's one that I can't pronounce. The name of the hospital is Amrita.
Okay.
But I'll let you know.
So how does somebody who lives on $2 a day handle a $7,000 surgery?
Oh, it's free.
Yeah, great question. So the Malawi government pays for the surgery for the most part. There's a very long waiting list for them to go. So not all of them can go that need to. And the Malawi government will pay for the flight there and the surgery, but not the passports. And so the passports are generally like $100 each, and the child and a guardian need a passport. And so, you know, which doesn't seem like a lot of money, but if you make $2 a day, that's a ton of money, right? And so I mean, we've done a lot of fundraising for passports, is kind of the bottom line. And then we've also done some fundraising to help the actual, you know, pay for some of the surgeries, because it's just so limited what the government does provide.
I'm curious about the Baylor Global Medicine Program.
Yeah.
I was not aware such a program
Oh, yeah.
existed.
Can you tell us more about it?
Oh, sure, yeah, and we have our experts back there also, so feel free to chip in. So Baylor has, it's Baylor and Texas Children's together, and we have I think the biggest global health, pediatric global health program in the nation. And it started through a program called BPI, Baylor International Pediatric AIDS Organization, and started and actually all of the clinics look exactly like the one I showed you on the first slide in, I think, 5 different countries. So we're in Malawi, Eswatini, which is in South Africa, Lesotho, Tanzania, Uganda, Romania, Botswana, Argentina, Colombia. Yeah, I got it. Okay. Yeah, and so started as a way to help children that have HIV. Because when I started in 2006, it was when antiretroviral therapy was starting to be very available for adults. And in Malawi, it was available to adults, and it was free. And adults were doing pretty well, but no one knew how to give it to children. And there were quite a few children back then. There are less now, but quite a few children who had HIV that they had acquired congenitally. And so basically, like, we were tasked to go to these places and help to train people to take care of children with HIV and how to give them medications and better take care of them. That's how we started. I don't know if you have anything else to add.
Yeah, just to say that, after the great work of doctors like Dr. Amy, we have been able to expand to meet the growing need of our patients who, no longer are dying of HIV/AIDS, but may have acquired cardiac diseases as a result of the medications that they're on, or as a result may have cancer, things like that. And so our program has been able to expand over the years to meet the needs of our growing patient population.
Amy, has Paul Klotman made it to Malawi? He's gone to Africa many times, and I've seen him.
Yes, Paul Klotman has, yeah, he came, 2 years ago?
Mm-hmm.
Yeah, so he came to Malawi 2 years ago. He also was in Botswana, and,
He was in Botswana, who
Yeah.
received the Presidential Medal of Distinction for the work that Baylor and Texas Children's have done for the people of Botswana last year.
yeah.
Do you know how much a new Philip would cost?
Unfortunately, a new Philips machine is about $90,000. Just why our old Philip has many Band-Aids on it.
Well, thank you, Dr. Amy, for
Thank you so
traveling
much.
so far. And now we need Lori and Hank. We have 2 bowls, and they need to draw the winning tickets. Jan, did you bring the bowls up? No, I haven't spread out. You got what? I haven't spread out here. All right.
Is that what it was? No, sure.
Okay. Oh, you got them all spread out. Oh, wow. Okay, so for the first Malawi bowl, we got a little description. These are handmade with a lathe, I think you all from the wood shop probably know about that better than I do. And it's a very hard wood. We're not quite sure what it is, but we call it African hardwood. And it is stained. Amy, maybe, what else do I need to say about it?
Oh, no,
That's it, okay. I'm picking a number. Oh, I wanted you to see this tablecloth because this is hand painted. And Amy used it at her wedding on the table, so for you all to notice this week. I have number 55. All right.
Who's that?
Junie? Was it Junie?
I know a lot of you have been staring at this thing that I'm wearing, and if you don't know, it is called a dashiki, which is what a mature African male would wear still. And you may remember during the civil rights movement that many of the civil rights people would wear a dashiki as a support for the civil rights. The number is 71.
So we'll be around and Amy will be around, take some questions and talk to her a little bit. So thank you all for